So this is a little unusual tibial condylar injury that does happen. It's a little different from normally what you would get, and with some disastrous complications. So,
good afternoon. Well, this is a 35-year female. She came with the injury that you can see here. And she came with an absent distal pulse. So any peculiarities of this injury, I would like to ask the panel that you.
This particular injury,
trifurcation is gone on the trifurcation. That's where the trifurcation is pointed out. That's where the trifurcation is as it's going.
The sharp spike of bone on the tertiary aspect, the anterior crushing of cortex as well as conduction of the cortex. That is putting the vessels to a great amount of
stress. That's where the vessels divide exactly at that point. That's where it goes.
So vascular injury is almost very likely with this particular pattern.
Yeah.
Subtle anything about reduction of this fracture? What do you introduce?
These type of cases where there is absent distal pulse, I will surely first go for fixator while before the vascular surgeon comes in. So distract, reduce it, then make the repair the vascular repair, and then do the scan, and then we can plan accordingly. This is the one indication where I will go for fixator.
Sandeep?
Probably the bones are soft. That is why the injury is an unusual pattern. A traction view would probably change or give a better picture. Just a traction.
So coming to Swapnil's thing, I think one important point is normally you put a fixator in 20 degrees of flexion. In this case, I put in more flexion because the vascular surgeons demand more flexion. So put it in a 40 degrees of flexion, you're doing it. So they find it easier. If you are doing it.
So the pulse may return if you reduce the impingement.
You're lucky because my main worry is that's where the trifurcation is. That's where the sharp point is. It's a very tough area. That's where it can bear. The repair is indicated. That's what happens.
The compartment, sir.
Okay.
Go ahead,
So
see that.
because the distal pulse was absent, we did a Doppler and we realized that there was a clot in the vessel, popliteal vessel, exactly at the site where there was a posterior angulation. And
But sir, do you have some different X-rays or traction X-rays?
no, unfortunately,
Scan?
I don't have. We had done the scan, but then unfortunately I don't have them. So when we explored, this was a segment of vessel which was completely thrombosed. So we had to excise that particular vessel and then put a graft and repair the vessel. And the pulse came back immediately on the table. See, the trick was that because the vessel was injured and it had to be explored, the approach which was taken was completely odd for doing any fixation. So what we had to do, because unless you do a skeletal stabilization, it is very difficult for the vascular surgeon to do the repair. So what we had to do was just temporarily fix the fragments by multiple K wires and allow him to get the repair done. And then once the vascular repair was in position, after some time, we went in and then we had to do the fixation with a plate. So the message in this particular case is that, the fixation in the first sitting is very, very tricky because the approach that is taken by the vascular people to repair is not the approach by which you can do the repair of or the fixation of your fracture fragment. So this is she had a little low-grade infection, so we removed the implant as soon as the fracture healed, and this is her function at the end of 10 months. So this particular situation, puts you in a fix about how you should do the fixation in the primary sitting. And as we all know, unless you do a skeletal stabilization, no vascular repair is going to sustain. So many a times you have to go in 2 stages and do the fixation at a second stage after doing primary stabilization.